Great. So we start. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 16C Hematology Non-Neoplastic Lesions of WBC. We are streaming live from IPGMER, Kolkata, India. And in continuation with our series of lectures on non-neoplastic lesions of WBC, this is session 3, where we'll be dealing with structure, receptor, and function of monocytes and macrophage. In short, the entire part of monocytes and macrophage with its classification and clinical manifestation of its disorders. And to speak on that, we have Dr. Shristi Butta. She is so good, and I don't think so she needs any more introduction. And today, unfortunately, she's not well, but still she has agreed to speak on the day. I hope she makes it. Dr. Shristi Butta, she's an MBBS honors gold medalist, MD pathology honors. Presently, she is a demonstrator in the IPGMER and SSKM Hospital, Kolkata, with areas of interest in cytopathology, hematopathology, and oncopathology. Before I start, one thing I would like to say that this shows the enthusiasm and the commitment of Dr. Butta. In spite of not being well, she still is, here to speak on the topic. Before I ask her to start, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. With this, let me ask, ma'am, please share your screen. Let's start.
My sincere thanks to Nadeem sir for giving me this opportunity. So yes, I wasn't well, but then I had my presentation ready, so I thought yes, I could do it.
Thank you so much.
Yes, sir. So, is my screen visible?
Yeah, just make it full screen.
Yes, sir.
Yeah, great.
Thank you, sir. So, a very good evening to everyone. We are here for the discussion of our third session on WBC disorders, non-neoplastic, including monocytes and macrophages this time. So monocytes express various receptors which monitor and sense environmental changes. Monocytes are highly plastic and heterogeneous and change their functional phenotype in response to environmental stimulation. Monocytes can differentiate in two respective subsets. One is the inflammatory and the other is the anti-inflammatory subset. Upon tissue damage or infection, monocytes can rapidly be recruited to the tissue where they can differentiate into tissue macrophages or dendritic cells. Monocytes and macrophages are critical effectors and regulators of inflammation and the innate immune response or the pre-programmed arm of the immune system. Dendritic cells, on the other hand, initiate and regulate the highly pathogen-specific adaptive immune responses and are central to the development of the immunologic memory and tolerance. The discovery of dendritic cells as a distinct lineage of mononuclear phagocytes specialized in antigen presentation to T cells and the initiation and control of immunity has revealed additional roles of these cells in shaping the immune response to pathogens. A detailed map of the relationship between monocytes, macrophages, and dendritic cells has shown the heterogeneity in the mononuclear phagocyte system. So we have a lot of mountains in India, isn't it? India is the home of some of the tallest and most gallant mountain ranges in the world. With this positive vibe, let's move on to the overview. Monocyte structure, function, and development will be discussed in the subsequent slides. Followed by that, we'll have macrophages, dendritic cells, monocytes and its associated disorders, macrophages and its associated disorders. Macrophage activation syndrome will be given a little bit of more stress, and then we'll have some key takeaways. So let's just move on. Monocytes. During a steady state, circulating monocytes have a half-life of about 1 to 3 days and maintain a steady state composition of monocyte subsets. Classical inflammatory monocytes are equipped with a set of toll-like receptors, the TLRs, recognizing the pathogen-associated molecular patterns. Monocytes are innate effectors of the inflammatory process and also kill pathogens by phagocytosis, yes, reactive oxygen species, nitric oxide production, myeloperoxidase, and other inflammatory cytokines, a range of it, yes. Now, what about the structure and function? Monocytes are a group of cells circulating the blood, bone marrow, and spleen and constitute about not more than 10% of the total leukocytes. They have a typical morphology. Yes, they have an oval to kidney-shaped nucleus with some cytoplasmic fascicles and vacuoles and a very high N/C ratio. Monocytes can remain in circulation for up to 1 to 2 days, after which they are removed by the process of apoptosis. Now let's look at the development. Okay, it's very interesting. Trust me. Monocytes originate in the bone marrow from the hematopoietic stem cells. Okay, the common myeloid progenitor, look at this cell here. These are the common myeloid progenitors, okay, which differentiates into the granulocyte macrophage progenitor. Okay, that in the presence of PU.1. Now, this is a very important chemokine here. Okay, it is important to note that this granulocyte macrophage progenitor subsequently differentiates into the common macrophage dendritic cell precursor. Okay, so here is the common macrophage dendritic cell precursor that finally differentiates into the committed monocyte progenitor. Now, this cell, that is the committed monocyte progenitor, is the recently identified bone marrow precursor. Okay, it's a recently identified bone marrow precursor because it lacks CD135 expression, unlike the macrophage dendritic cell precursor, which has a CD135 expression. Subsequently, what happens is that this committed monocyte progenitor differentiates into two sets of monocytes. Now, these are the two subsets of monocytes that we were talking about. Okay, that is the inflammatory ones, or also referred to as the LY6C high type of monocytes. Okay, now what is this will be discussed in the subsequent slides. For the time being, you just need to know that this is one subset and this is the other subset. One shows an LY6C high type and the other is the LY6C low type. Moving on further, this macrophage dendritic cell precursor also differentiates into the common dendritic cell precursor. Now, what does this do is that differentiates further into classical dendritic cells and the plasmacytoid dendritic cells. We also must remember that this granulocyte macrophage progenitor also differentiates into neutrophils. Okay, so it's very interesting. Let's see how does all that happen. It was first reported in the 1970s that monocytes increase proliferative activity in the bone marrow in response to inflammatory stimuli, leading to what is referred to as monocytosis. Migration into tissues and differentiation of monocytes to inflammatory dendritic cell, or for that matter macrophages, is determined by the inflammatory milieu and the macrophage and the pathogen-associated recognition receptors. Okay, moving on quickly to macrophages. Macrophages are resident phagocytic cells in lymphoid and non-lymphoid tissues. Yes, it's very well known to us. Recent studies have revealed that they have a diverse origin. Besides taking origin from the monocytes, they also take origin from yolk sac progenitors like the microglia for that matter, okay, which arises exclusively from the yolk sac progenitors independent of the hematopoietic stem cell precursors in the bone marrow. We also have the Langerhans cells, alveolar macrophages, and the Kupffer cells, for instance, which initially take origin from yolk sac progenitors but are subsequently replaced by the fetal liver-derived monocytes. Macrophages in the heart, pancreas, gut, and dermis, in contrast, are originally derived from the fetal liver monocytes, but later on they are replaced by the bone marrow-derived monocytes. Osteoclasts, yes, they are the bone macrophages. They are generated from the mononuclear phagocyte lineage in the bone marrow, and their differentiation from osteoclast precursor depends on the CSF1. Now, this CSF1 and the engagement of the rank, that is, the receptor activator of nuclear factor kappa, okay, that is the rank L with its rank L ligand, okay, rank with the rank L ligand, and with CSF1, that is very specific for osteoclastic development. Recently, however, it has been shown that even interleukin 34 is involved in the osteoclastic development. Let's see what is this interleukin 34 in subsequent slides. Now, monocytic heterogeneity, the new nomenclature that groups monocytes into 3 basic subsets. Now, that has now recently been approved by the Nomenclature Committee of International Union of Immunologic Society. These are dependent on 2 markers, the surface markers CD14 and CD16. Based on this nomenclature, the major population of human monocytes, that is about 90% of it, okay, has a very high CD14 expression, but a no CD16 expression. Remember, a no CD16 expression, and they're referred to as the classical monocytes. Okay, so a very high CD14 expression with no CD16 expression is classical monocytes. Okay, moving on further, a minor population, that is about 10%, okay, has been divided into the intermediate subset with low CD16 and very high CD14. So it has a low CD16 and this had a no CD16, okay. On the other hand, we also have the non-classical subset, which has a very high CD16 expression with relatively lower CD14 expression. Okay, that is CD14 is low or dim. So we have the 3 groups. We have the classical, we have the intermediate, and we have the non-classical subset. In general terms, however, this classical and intermediate subset is now grouped into the inflammatory monocytes. Okay, this inflammatory monocytes in humans correspond to the LY6C positive monocytes in mice. Yeah. Okay, so this LY6C is very important because now it is used as an immunohistochemical marker for ascertaining monocyte and macrophagic disorders. Okay, so that is really important. The non-classical monocytes, on the other hand, are those which have a very high CD16 expression but no or low CD14 expression, and they are referred to as the patrolling monocytes. Okay, so what is these patrolling monocytes? What are these patrolling monocytes? Will be discussed in subsequent slides. So if we sum it down to, we have 2 types of monocytes now. We have the inflammatory monocytes, okay, which is also referred to the LYC6C positive or high, and the resident or patrolling monocytes, which is the LY6C low monocytes. Now, the inflammatory monocytes, okay, express very high levels of the chemokine receptor CCR2 and a low level of the chemokine receptor CX3CR1, whereas patrolling monocytes show a reverse pattern. Okay, this is again very important. Let's see. It's all associated with diseases, you know. Let's see. Accordingly, inflammatory monocytes respond to CCL2 chemokine. Okay, so because, just remember that inflammatory monocytes express very high levels of CCR2, okay, chemokine receptor CCR2, and lower levels of CX3CR1. Therefore, they respond to the chemokine CCL2 that mediates CD14 positive monocyte recruitment to the inflammatory sites, right? Moving on further, these patrolling monocytes, on the other hand, respond to CXC chemokine ligand 1, a chemokine present on soluble proteins and as membrane-bound chemokine form that is expressed on endothelial cells and in tissues. So it is very important that it responds to this chemokine ligand, okay, and that is why, because that is present on the endothelial cells. So the patrolling effect of these monocytes is linked to somewhat the expression of this chemokine on the endothelial cells. So if we sum it down to this fact that hematopoietic stem cells in the presence of PU.1, which is an extremely important factor, which allows for the conversion of this hematopoietic stem cell into the common myeloid progenitors, which subsequently changes into the monoblast, promonocyte, monocyte. Again, monocyte is differentiated into two types. That is the LY6C positive or the inflammatory monocytes, which move on to the kidney, brain, heart, lungs, intestine, liver, spleen, skin. Yes, everywhere you've got macrophages in different names. And then you have your peripheral blood resident monocytes, which have a patrolling effect, okay, on the endothelial cells. That is, they are maintaining the surveillance. Now, coming to the monocytic heterogeneity. If we talk about inflammatory monocytes, these are so named because these monocytes are the ones which differentiate into macrophages. On different sites, you have the kidney, lungs, liver, etc., and the dendritic cells. So these monocytes differentiating into the dendritic cells that produce inflammatory mediators like the tumor necrosis factor alpha, nitric oxide, and the reactive oxygen species. We also have the LY6C low monocytes, which represent the patrolling monocyte subset. They are characterized by a smaller size. Remember, they are much smaller than these monocytes. They lack the expression of CCR2. Yes, CCR2 expression was very high in the inflammatory subset, and also lack the expression of L-selectin. But rather, they have a very high expression of integrin LFA1, which allows it to bind to the endothelium and allows it to undergo patrolling. Now, what is that? Intravital microscopy has revealed that these low LY6C low monocytes exhibit a long-range crawling effect on the luminal aspect of the vascular endothelium. So what they do is that they crawl onto the luminal aspect of the vascular endothelium, okay, and are ideally located to survey the endothelial cells and the surrounding tissue for damage or infection. So they're somewhat like the policemen, okay? They always show this property of patrolling, okay? It must also be noted that LY6C low monocytes are recruited at a late phase to the ischemic myocardium, where they express the VEGF and are proposed to promote healing via myofibroblast accumulation. So that is interesting, right? Because they even express VEGF, which is an angiogenic factor, and also promote myofibroblast accumulation, angiogenesis with fibroblast accumulation. Okay, so that is what is happening in the ischemic myocardium, and that is being assisted by these typical monocytes. Okay, so if we sum it now as monocytes in the presence of granulocyte, macrophage colony stimulating factor, and interleukin 4, okay, changes into dendritic cells. In the presence of TGF beta 1, changes into Langerhans type of dendritic cells. In the presence of MCSF, changes into macrophages. In the presence of MCSF and interferon gamma, changes into M1 type of macrophage. In the presence of interleukin 4, it changes into an M2 type of macrophage. So this is just a gist of the cytokines and how does a monocyte respond to it. Under homeostatic control, remember I'm talking about the homeostatic control, monocytes or macrophage development is mostly influenced by the CSF1, or we also refer to it as the monocyte or macrophage colony stimulating factor, MCSF, which is typically produced by the stromal cells within the bone marrow and also in the tissues. Mature mononuclear phagocytes express the CSF1 receptor, okay, that is the receptors for the MCSF. However, it must also be noted that there's a recent cytokine, that is IL-34. Remember the osteoclastic development where we were discussing about this IL-34, which is also implicated in the development of the osteoclasts? So recently, this cytokine has been identified as being able to bind and signal through the CSF1R receptors. So it must be noted that the CSF1R receptor is expressed on the surface of the monocytes, right? Okay, so unlike broadly expressed this CSF1R receptor, okay, interleukin 34 expression is restricted, however, to the epidermis and the central nervous system. So there it allows for the production of the Langerhans type of cells, yes, and you have the microglia. So that is very important. Granulocyte macrophage colony stimulating factor, however, is unlike the colony stimulating factor or the monocyte macrophage colony stimulating factor. How is it different? This is because it is involved in the development of the mononuclear phagocytes, but under inflammatory conditions and not under homeostatic conditions. So it is when it's homeostatic, it is the monocyte or macrophage colony stimulating factor. On the other hand, the granulocyte macrophage colony stimulating factor allows for the production of neutrophils and not monocytes or macrophages under homeostatic condition. Okay, it only allows for the production of monocytes and macrophages under inflammatory conditions. So that is typically very important, right? Now, what about the PU.1 we were talking about? Now, this factor is very important because it is required for the earlier steps of the development of the common myeloid progenitors. Okay, it is important because it allows for the development of the myeloid lineage cells, and a general deficiency of the myeloid lineage cell is usually associated with the deficiency of PU.1. PU.1 has additional key selector gene functions at several branch points of the myeloid lineage, particularly during the macrophage versus dendritic cell choice of monocytes. Intermediate expression, okay, of this PU.1 in the granulocyte macrophage progenitors can overcome the neutrophil fate inducing effect of the basic leucine zipper transcription factor SEPA. Okay, so however, it must be noted, if we just simply put it, it is the intermediate expression of PU.1 in the granulocyte macrophage progenitors which can overcome the neutrophil fate, okay, and allow for the production of macrophages. A higher expression of PU.1, on the other hand, allows for the expression of neutrophils. A macrophage colony stimulating factor that we were talking about, that is the MCSF, also called as the CSF1, okay, and the granulocyte colony stimulating factor, also called as the GMCSF, drive the monocyte macrophage development, differentiation, and proliferation, along with the cytokines, like that is interleukin 4, and for that matter, the recently developed interleukin 34. Okay, however, the macrophages and circulating monocytes express the CSF1R, that is the CSF1 receptors. The CSF1 is constitutively produced by the mesenchymal cells and is detectable in circulation in the resting conditions. Under homeostatic conditions, CSF1 promotes monocyte development and macrophage proliferation, which is controlled in a negative feedback loop. Okay, so that is very important. In fact, mature monocyte precursors, or the mononuclear phagocytes for that matter, express high levels of the CSF1R and are responsible for the clearance of CSF1. The decreased expression of CSF1 levels leads to a decrease in the mononuclear cell proliferation. Okay, so that is very important. If you have these mononuclear phagocytes expressing a very high level of this receptor, there will be excess. That will be responsible for the clearance of the CSF1. Okay, so CSF1 expression would assist in the development of these mononuclear phagocytes. However, an increased expression of the CSF1R will be responsible for the clearance of these mononuclear phagocytes in the negative feedback loop. Therefore, CSF1 and GMCSF, okay, that is the MCSF and the GMCSF, are both involved in the monocyte macrophage functional differentiation programs. CSF1 or the MCSF leads to homeostatic or anti-inflammatory M2-like phenotype, whereas the GMCSF leads to an M1-like inflammatory phenotype. So that is very important. This is because the GMCSF allows for the production of the monocytes only under inflammatory conditions. And as we all know, the M1 phenotype of the monocytes or macrophages corresponds to the inflammatory phenotype. On the other hand, the M2 phenotype corresponds to the anti-inflammatory phenotype. So that is because the CSF1 or the MCSF leads to homeostatic or anti-inflammatory or M2 phenotype of the macrophages. So lots and lots of cytokines, right? Let's look at this now. India is a land of attractive sceneries and ecosystems. Okay, yeah, it's marvelous, isn't it? Now moving on to the function of monocytes. We have two subsets, as we've already discussed. We have the LY6C positive or the inflammatory subset, okay, which is responsible for, under steady state conditions or homeostasis, for the replenishment of the monocyte-derived macrophages in the tissues. On the other hand, we also have the LY6C negative subset, which is responsible for the patrolling effect and surveillance of the luminal surface of the endothelium. It also senses viral nucleic acids. Okay, that is also important. Inflammation, on the other hand, we have inflammatory. So these are the inflammatory monocytes. They are responsible for the M1-like phenotype. Okay, and as well as they are responsible for the antigen uptake in the tissues, recirculation to the lymph nodes, antigen presentation in the lymph nodes, also referred to as the tissue monocytes or rather macrophages. Two sides of the same coin. Now, LY6C negative, on the other hand, are responsible for promoting healing of the ischemic myocardium. Remember, we discussed that LY6C negative macrophages are responsible for the anti-inflammatory and fibrogenic effect, and that is why it produces more of myofibroblasts and also produces VEGF, which is responsible for the angiogenesis. Now, M1, M2 paradigm. What is this? Yes, we already know this, right? The M1 type is the classically activated macrophages, okay, which produce the reactive oxygen species, nitric oxide, lysosomal enzymes, all of which are responsible for microbicidal killing activities, phagocytosis, killing of bacteria, and killing of fungi. Okay, what about the other inflammatory markers? Yes, we have other cytokines like interleukin 1, 12, 23, other chemokines, all responsible for what is referred to as inflammation. Okay, so it is the interferon gamma and the microbes which are responsible for the activation of the M1 phenotype of the macrophages. On the other hand, we have interleukin 30 and typically interleukin 4, okay, which is responsible for the alternatively activated macrophages or the M2 phenotype, which is responsible for the growth factor production and the TGF-beta production, which is responsible for tissue repair and fibrogenesis. In addition, we have interleukin 10 and TGF-beta, which also exert some anti-inflammatory effects. Now, this is the standard thing that we knew of, right? However, we also have another set of monocytes. Okay, the phenotypic changes and functional polarization of macrophages are accompanied by a change in the cellular metabolism, as M1-like macrophages primarily rely on glycolysis. Okay, we didn't know that, right? The M1 type macrophages rely on glycolysis, whereas the M2-like macrophages rely more on oxidative phosphorylation. Parallel analysis of macrophage metabolic and transcriptional profiles also indicate that the metabolic reprogramming impacts the macrophage polarization and/or activation. Now, what are the two other distinct types of macrophages then? We have the tumor-associated macrophages. Now, this is a distinct macrophage subset, okay, which is particularly abundant in cancers and exerts a strong influence on tumor initiation, progression, and metastasis. Besides that, TAMs can also secrete different cytokines like interleukin 10 and TGF-beta, okay, somewhat similar to the M2 type. Okay, to suppress the T-cell dependent anti-tumor function. TAMs can be polarized to the pro-inflammatory as well as the anti-inflammatory subset under the stimuli of different tumor microenvironments, with the majority of TAMs functioning as M2-like macrophages. So we have a set of macrophages which can function as both the M1 as well as the M2. They are the tumor-associated macrophages. We also have the ATMs. Now, what is this ATM? Anytime money? No. It's the adipose tissue macrophage. They are the central players in the obesity associated inflammation and metabolic diseases. Macrophages are involved in lipid and energy metabolism and mitochondrial function in adipocytes. Macrophage polarization is accompanied by metabolic shifting between glycolysis and mitochondrial oxidative phosphorylation. It seems that the ATMs develop from the circulating monocyte accumulating in the adipose tissue. They self-renew from various tissue-resident macrophages and proliferate in situ, driven by the monocyte chemotactic protein, that is the MCP1. We also have the dendritic cells. Now, when we have the dendritic cell, look at this, we have the bone marrow hematopoietic stem cell, okay, that differentiates into the myeloid precursor and the lymphoid precursor. The lymphoid precursor gives rise to the NK, T, and B cells, very well known to us. In addition, this lymphoid precursor also gives rise to the plasmacytoid dendritic cells. On the other hand, this myeloid precursor, besides giving rise to the monocytes, also differentiates into the myeloid dendritic cell, the follicular, and the Langerhans type of cells. Okay, just look at this diagram. Okay, it'll just give you a clue to the complexity within the dendritic cell. The dendritic cell originates from the hematopoietic stem cell precursors, okay, that gives rise to the myeloid and the lymphoid precursors. We've already discussed the lymphoid precursor again changes into the NK, T, and other types of cells, okay, as well as the plasmacytoid dendritic cell. This plasmacytoid dendritic cell, okay, can also be generated from this, that is the common dendritic cell precursor. Where does this come from? We have the myeloid precursors, which differentiates into the myeloid dendritic cell precursors, okay, that can give rise to monocytes here, okay, and it can also give rise to the common dendritic cell precursor. This common dendritic cell precursor can either change into the plasmacytoid dendritic cells, as we've already discussed, and can also change into the classical dendritic cells. This classical dendritic cell can be of two types, okay, that is classical dendritic cell type 1 and type 2. Okay, let's see what is that. Now, this classical dendritic cell type 1 expresses a lot of CD markers, okay, that is CD1, 41, XCR1, etc. See, now this classical type of dendritic cell has two types, okay, that is the two subsets of classical dendritic cells, that is the type 1 and the type 2. The type 1 primes the CD8 plus T cells, that is the cytotoxic T cells, okay, which is responsible for the anti-tumor and antiviral immunities. Okay, what happens further down is that the classical dendritic cell type 1 are found sparsely distributed along the tumor margins, and they compete with the tumor-associated macrophages. Okay, and their presence is important for the cytotoxic effect because they are the ones which are priming the CD8 plus T cells. On the other hand, the classical dendritic cell type 2 are potent stimulators of naive T cells, okay, and they can show properties of inducing T helper 1, T helper 2, and T helper 17 responses. Now, they are responsible for the recruitment of neutrophils, right? So, they are the ones which are responsible for activating the naive T cells, subsequently releasing these helper, T helper 1, 2, and 17. Now, what is the ZBTB46? Now, this is a new and specific marker for classical dendritic cell. Its expression is restricted to classical dendritic cell as a mature hematopoietic stem cell marker. Okay. Besides that, it can also be found in the erythroid and the endothelium, but however, being restricted to the classical dendritic cells along the mature hematopoietic cells. Okay. ZBTB46. Why is it restricted? This is because the common dendritic cell precursors and especially the pre-dendritic cells contain a distinct fraction of this ZBTB46 cells, okay, which can give rise only to classical dendritic cells and not to plasmacytoid dendritic cells when seen in culture. Okay, and so in the human body as well, this has been implicated. Now coming to the plasmacytoid dendritic cells. Plasmacytoid dendritic cells are a unique dendritic cell subset. Okay, they are different. They are different from the classical dendritic cells. How? Because they are specialized in the production of type 1 interferons, okay, that is the interferon alpha and beta, and that is responsible for the antiviral effect. Plasmacytoid dendritic cells are important not only in the production of type 1 interferons, okay, but also cause overexpression of MHC class 2 and the co-stimulatory molecules, okay, which are responsible for CD4 plus T cell stimulation. Now, there are two types of dendritic cells we've already discussed. However, whenever a dendritic cell undergoes stimulation, okay, in the form of pathogens, cytokines, pathogen-associated molecular patterns or damage-associated molecular patterns, it changes from its immature type to a mature type. Okay. Subsequently, there is a change in the co-stimulatory molecules MHC class 2 expression, secretion of pro-inflammatory cytokines, phagocytic capacity changes, okay, and CCR7 expression and glycolysis and its effect changes as well. Now, these dendritic cells are found to be in two functional states, as we've already discussed. There are distinguishing features, okay, but the ability to activate antigen-specific naive T cells in secondary lymphoid organs is a hallmark of the mature dendritic cell. Dendritic cell maturation is triggered by the pathogen and the damage-associated molecular patterns. Maturation, in turn, can be metabolic, cellular, or gene transcription level of maturation, okay, and that allows the dendritic cells to migrate from the peripheral tissues to the T cell dependent areas in secondary lymphoid organs. Lymphocytes, their development and role and their disorders will be discussed in the next class, however. Thus, the interaction between the mature dendritic cells and the antigen-specific T cells is a trigger for antigen-specific immune response. When interacting with the CD4 plus T cells, dendritic cells may induce their differentiation into T helper cell subsets. Now, monocytes. Now, monocytes act as a double-edged sword, let me tell you that. Okay, it not only causes liver fibrosis by producing TGF-beta and interleukin-10, but it also causes fibrosis regression by producing MMPs. That is the matrix metalloproteinases. It not only causes muscle injury, but also muscle regeneration. In Alzheimer's, it causes deposition of the beta amyloid plaques as well as causes its clearance. Let's see, how does that happen? Based on the recent scientific data, critical role of these monocytes in the pathogenesis of liver fibrosis, atherosclerosis, Alzheimer's disease, autoimmune diseases like multiple sclerosis, and interestingly, even tumorigenesis has been reported. Yes, they behave like a double-edged sword, and monocytes can play variable roles. Now let's come to infections and injury. Monocytes are crucial for an effective immune response. Recent data suggests that monocytes, especially the classical inflammatory subset, remember the LY6C positive or the high or the inflammatory subset with very high expression of CD14 and low or no expression of CD16, they use the CCR2, remember the CCR2, for their emigration from the bone marrow into the blood circulation. So they emigrate by using the CCR2 from the bone marrow into the blood. Moreover, during infection, the circulating TLR, okay, ligands can induce the synthesis of MCP1. What is this MCP1? This is the monocyte or macrophage chemotactic protein. Okay, so what does this do? This is a major binding partner for the CCR2. Remember that these inflammatory monocyte subsets express CCR2 and that binds to the MCP1. Now, where does this MCP1 come from? It occurs, or rather it comes from the fact when there is an infection and these TLR ligands induce a synthesis of MCP1 by the bone marrow mesenchymal cells and progenitor cells. Okay, and that enables the monocytes to exit from the bone marrow and move under the action of MCP1 to the site of infection. Okay, so this is the monocyte chemotactic factor. Although neutrophils are immediate responders to any infection or injury, monocytes are the key players in modulating the inflammation. They also produce cytokines like interleukin 1 beta, the pyrogen, okay, and we also have interleukin 6 TNF alpha, as well as the inducible nitric oxide synthase, thus controlling the early phase of different infections or injury. Regarding the liver fibrosis, which occurs typically with viral infections, which may be hepatitis B or C virus, chronic alcoholism, there is deposition of type 1 collagen into the extracellular space. Okay, and that typically occurs because of the production of TGF beta 1 and the profibrogenic interleukin 10. On the other hand, it must be noted that these infiltrating monocytes can also differentiate into macrophages. These macrophages produce the matrix metalloproteinases, which were discussed in the last class, and that degrades the collagen type 1 deposit and facilitates fibrosis regression. Regarding atherosclerosis, we all know that the thickening of the arterial wall by the cholesterol accumulation, or the so-called atherosclerosis, is one of the leading killers in the modern world. Okay, among the other etiologies, chronic inflammation to the arteries, which leads to the accumulation of macrophages or foam cells, and their defective clearance of the LDL protein, is the major cause of atherosclerosis. The inflammatory monocyte accumulates in the atherosclerotic plaque by using the chemokine receptors, remember the CCR receptors and the CX3CR1. That plays a very important or major role in plaque progression. What about tumor progression? We have the VEGF, the angiogenic factor, produced by infiltrating inflammatory monocytes. They have been studied in breast cancer, and that has been associated with tumor metastasis to lungs. Okay, VEGF has been associated with a lot of other tumors, even in renal cell carcinomas, meningiomas, yes, gastric tumors, everywhere. It has been found that blocking the CCL2 or the MCP1, the major monocyte chemoattractant, the ability of the tumors to undergo metastasis is reduced. These findings indicate a crucial role of these inflammatory CCR2 positive monocytes. Remember the inflammatory subset of monocytes in carcinogenesis. So these monocytes are not only involved in infections, injuries, atherosclerosis, but also in carcinogenesis. Very interesting, right? Very recently, it has also been found that the tissue factor expressed by tumor cells correlates with the infiltration of monocytes and macrophages. It also correlates with tumor cell survival and metastasis. Hence, pharmacological inhibition of tissue factor mediated coagulation can abrogate the monocyte macrophage recruitment and allow for tumor cell survival. Now, coming to the approach to the diagnosis of monocytosis. Monocytosis, by definition of WHO, is a persistent high absolute monocyte count of more than 1 into 10 to the power 9 per liter, with monocytes accounting for more than 10% of the leukocytes and persisting for more than 3 months. However, if we consider the normal monocyte count, then that ranges between 0.2 to 0.8 into 10 to the power 9 per liter, and obviously accounts for less than 10% of the total leukocytes. Under normal physiological conditions, monocytes are usually much higher in males as compared to females. Now, what are the causes of monocytosis? When we come to the reactive causes, we have transient and we have persistent causes. Transient causes may be bone marrow recovery, exercise-induced, maybe acute infections, splenectomy, medications, myocardial infarction, maybe stress. Persistent monocytosis typically occurs when you have chronic infections, rheumatological conditions, medications. Clonal causes are not the topic of discussion for today, though acute neoplasms like acute monocytic or myelomonocytic leukemias, dendritic cell leukemias, chronic neoplasms like CMML, JMML, etc. are all associated with monocytosis. When approaching a patient with monocytosis, it is very important in assessing the chronicity and the pattern of monocytosis, along with a comprehensive history and physical examination. Morphology of the monocytes should be confirmed on peripheral smear to assess for any dysplasia. Monocytosis plus dysplasia or any additional abnormality like anemia, thrombocytopenia, eosinophilia, or basophilia for that matter, or maybe splenomegaly as clinical indicator, bone pain, weight loss, all give you a clinical clue to the clonal origin of the disease. In addition, pathologically thinking, we can use some cytogenetic molecular markers. We can do some dual staining with alpha naphthyl butyrate esterase and naphthol ASD chloroacetate esterase. Okay, that is the CAE. May be helpful in distinguishing the monocytic component from the monoblastic or the pro-monocytic component. If we have a dual staining, remember it's dysmyelopoietic, whereas a pure staining of the monocytic cells with only alpha naphthyl butyrate esterase is typically monocytic. In the absence of dysplasia and isolated monocytosis, a repeat blood count should be considered at least after 3 months. Resolution of monocytosis within 3 months is usually indicative of a reactive etiology. Now, coming to monocytosis, this is just a chart telling you what we've discussed till now. If you have monocytosis, you must allow for confirmation of the morphology on a peripheral blood smear, whether you see dysplasia or you don't. Okay, if you see dysplasia, obviously you should go in for a bone marrow evaluation, followed by a bone marrow aspiration and biopsy, subsequently immunophenotyping. And if there's no dysplasia, in that case you can repeat a CBC after 3 months. And if the monocytosis resolves, it is likely that it was a reactive condition. However, if you have a persistent monocytosis, then looking for reactive causes. We've already discussed the reactive causes. Okay, and then you must see the monocyte compartment flow, or flow cytometry can be done. Expansion of CD16 positive fraction. Okay, remember the CD16 positive fraction or the non-classical fraction of monocytes that we discussed. Okay, that is more suggestive of a reactive etiology. Okay, so if you have the non-classical form here, where you have very high CD16 expression for that matter, then that indicates a reactive etiology. On the other hand, if you have a low or no CD16 expression with a high CD14 expression, that is a classical subset. But however, it is more than 94%, okay, and absence of any other reactive cause, then in that case, that is more suggestive of a CMML. So the reason why we discuss the CD14 and CD16 expression in monocytes comes here, okay? So what is the need of dividing the monocytes into different subsets, the inflammatory and the classical subset, or the non-classical subset, or the patrolling subset? Okay, all comes down to here. Okay, you can easily distinguish a CMML from a reactive monocytosis by simply doing a CD14 and CD16. Now, coming to monocytopenia. Monocytopenia is a reduction in the blood monocyte count, okay, which is less than 500 per microliter. Chemotherapy-induced myelosuppression, hematopoietic cell mutation, particularly involving the GATA2 gene, has been implicated in monocytopenia. In addition, we have neoplastic disorders like hairy cell leukemia, ALL, Hodgkin lymphoma, infections like HIV, Epstein-Barr virus, adenovirus, biliary tuberculosis. We also have corticosteroid, yes, they are immunosuppressive, and gastric intestinal resections. There may be a transient monocytopenia, particularly in endotoxemia, hemodialysis, and cyclical neutropenias. Early monocytopenia after chemotherapy is a risk factor for neutropenia. So that must also be kept in mind. If you have an early monocytopenia after chemotherapy, then that will result in neutropenia subsequently. A decreased monocyte blood count has been implicated in patients having rheumatoid arthritis, SLE, aplastic anemia, and AIDS. So cyclical neutropenia may be associated with an intermittent monocytopenia. So that is also to be kept in mind. Now, what is this GATA2? Haploinsufficiency of the primitive hematopoietic transcription factor GATA2. Now GATA2 is very important because it is involved in the proliferation of the lymphocytes, monocytes. So they are the hematopoietic precursor. And it is a very primitive hematopoietic transcription factor. So what does the syndrome include? It includes not only the monocytopenia, but also a lymphocytopenia. So a profound B and NK lymphocytopenia as well as monocytopenias are strongly suggestive of GATA2 deficiency. Okay, and therefore that should prompt a genetic testing for GATA2. GATA2 mutations also account for significant percentages of pediatric neutropenias and idiopathic CD4 lymphocytopenia and even aplastic anemia. Now coming to glucocorticoids or corticosteroids, they have an anti-inflammatory or immunosuppressive effect. As we all know, they suppress the production of numerous cytokines and vasoactive substances, including interleukin-1, TNF-alpha, interleukin-2, MHC class 2 chemokines, and prostaglandins. Okay, so lots and lots of chemokines and cytokines and receptors and everything. Just a break. Okay, now we have macrophage and its associated disorders. We all know Gaucher's disease, right? The Gaucher's disease is associated with the deficiency of glucocerebrosidase. Okay, now it is important to note that Gaucher's disease, now these are the Gaucher's cells here. It's a disease which is associated with a genetic lysosomal hydrolase deficiency. Okay, besides that, we also have disorders like hemosiderosis, which is responsible for the iron accumulation. Remember, a secondary iron accumulation in the reticuloendothelial system. Hemochromatosis, on the other hand, is associated with a primary iron overload. We also have infections and inflammations, particularly the asbestosis, rheumatoid arthritis, and inflammatory bowel diseases, which are associated with macrophage and a defect in the intracellular killing. Infections like septic shock, malaria. Hello?
Hello. Hello. Oh, tell me. Hello, go ahead, tell me.
Okay.
Hello.
So infections.
Hello.
Infections like septic shock, malaria, AIDS, dengue, etc. We also have the metabolic injuries in atherosclerosis, Alzheimer's disease, and malignancies like cancer, where the macrophage within the tumor microenvironment facilitates angiogenesis, as we've already discussed, extracellular matrix remodeling, and promotes tumor cell multiplication.
I called up Monima. He was busy with patient. He said he'll call back at 8:30 and talk to him. He has got
Sir, can you mute yourself, sir?
I'll just call you back in a minute. I'll call you back.
Sir, can you mute yourself? Now moving on quickly to macrophage activation syndrome. Now this is a very important topic for all postgraduate trainees. Yeah. So macrophage activation syndrome is a phenomenon characterized by cytopenias, organ dysfunction, and coagulopathy associated with an inappropriate activation of macrophages. It is characterized by an uncontrolled activation and proliferation of T lymphocytes and macrophages. Macrophage activation syndrome is currently classified as a secondary or acquired form of HLH. Yes, the hemophagocytic lymphohistiocytosis. It is the secondary form. The reason why macrophage activation syndrome shares its clinical and laboratory features is the basic reason why it has been grouped as a hemophagocytic lymphohistiocytosis. So this is a picture here, down here. Okay, you have this phagocyte here, okay, which has engulfed these NRBCs here. Okay, so this is the hemophagocytic lymphohistiocytosis. It may also engulf lymphocytes and other leukocytes. Macrophage activation syndrome is typically characterized by high fever, lymphadenopathy, hepatosplenomegaly, variably associated with hemorrhage, signs of liver and central nervous system involvement, as well as kidney involvement and multi-organ failure. Okay, we'll be going and discussing its pathogenesis as well in the next few slides. Laboratory abnormalities include a decrease in the white blood cell count, okay, platelets and hemoglobin, hypertransaminase, marked increase in ferritin, and evidence for intravascular coagulation activation. So let's see the classification of HLH. Here you go. You have the primary HLH, okay, which is familial. Okay, it is associated with a deficiency and genetic mutations in the PRF, UN, C1, 13, etc. Okay, we have the secondary HLH. Now, this secondary HLH is the one which is called as the macrophage activation syndrome. It may be associated with viral infections. Okay, we have the Epstein-Barr virus, cytomegalovirus, parvovirus, herpes simplex virus, HIV, and also the novel coronavirus. You also have malignancies like leukemia and lymphoma and some autoimmune conditions. Okay, like the juvenile idiopathic arthritis, adult onset Still's disease, SLE, systemic sclerosis, etc. Now, coming to the pathogenesis, now where the monocyte system comes into direct contact with the circulation in the liver, spleen, and bone marrow, a physiological mechanism exists for the removal of these worn out red blood cells. Okay, a predominant dysregulation of this system is what results in this classical cytokine storm. Okay, and that subsequently results in DIC. How does that happen? Let's see. Now, here you go. You have a life-threatening hyperinflammatory condition that develops. Okay, and there is release of pro-inflammatory mediators. Defect in the perforance mediated cell lysis of activated CD8 cytotoxic T cells and dendritic cells. Activation and proliferation of these cells results in overactivation and proliferation of macrophages. A hypersecretion of these cytokines results in the cytokine storm. Okay, and that subsequently causes phagocytosis. But how does that happen? Okay, let's move on. What happens is that you have the classical macrophage activation syndrome and hemophagocytosis. First of all, the cytokine storm occurs due to the release of inflammatory mediators by the neutrophils, monocytes, and macrophages. So these inflammatory mediators that are being released are released by not only neutrophils but also monocytes and macrophages. What is happening subsequently is that the engagement of these inflammatory mediators, especially the interleukin 6, okay, remember we check IL-6 levels in COVID patients, but why? The reason is because this interleukin 6 receptors, which are present on the endothelial cells, get activated when this interleukin 6 goes and binds to it. That subsequently activates the JAK-STAT pathway, okay, and that in turn upregulates adhesion molecules like the VCAM1, ICAM1, E-selectin, and the MCP1. Okay, so what happens subsequently if these ICAM1, VCAM1, MCP, L-selectins all are activated? Increased adherence happens to the endothelium. So here you go. Cytokine storm leads to a capillary leak syndrome. There is increased adherence of these cells to the endothelium, and that subsequently results in a capillary leak syndrome. Okay. Therefore, there is a release of edematous fluid and adherence of more neutrophils and macrophages to the endothelium that triggers a procoagulant property of the endothelium and results in what is referred to as DIC. Okay, so DIC and subsequent multi-organ failure, which may involve lungs, kidney, liver, etc. So the term cytokine storm entered this popular lexicon of us with previously influenza virus pandemic, but now it's now a very common word for all of us, right? Especially in this era of SARS-CoV-2. Macrophage activation syndrome is characterized not only by fever, variable hepatosplenomegaly, but elevated CRP levels, hyperferritinemia, phagocytosis, especially the hemophagocytosis, and coagulopathy. So what is the diagnostic criteria? The diagnostic criteria, it involves the clinical criteria, which I've already discussed. There's fever, there's splenomegaly. It involves the laboratory criteria, that is the hemoglobin less than 90, that is 9 grams per dl. Okay, it is important to know that platelets may be low. Together with that, neutrophils, hypertriglyceridemia, hypofibrinogenias, fasting triglyceride levels are very high, and fibrinogen levels are low. Histopathologic criteria involves hemophagocytosis in the bone marrow, spleen, or lymph nodes with no evidence of any malignancy. And the newly added criteria includes the low or absent NK cell activity, increased ferritin levels, and a high soluble CD25 or interleukin 2 receptor levels. The diagnostic criteria involves 5 out of 8 of these. So finally, we've reached, right? Look at these snowy peaks of the Everest here. Beautiful, isn't it? So what are the key takeaways? Monocytes consist of two principal subsets. Yes, they are the inflammatory and the patrolling monocytes. Yes, they are the Ly6C positive and the Ly6C negative monocytes. Ly6C, a very important immunohistochemical marker or the flow cytometric marker. Inflammatory subsets employ CCR2 to emigrate from the bone marrow under the influence of MCP1. Monocytes differentiate both into macrophages and or dendritic cells and thus modulate innate and adaptive immune responses. Monocytes are involved in every disease process, very important, every disease process in which there is persistent tissue injury or a metabolic disturbance. They mediate acute as well as chronic inflammation, promote repair through removal of dead cells, and fibrin by phagocytosis and fibrinolysis, induce blood vessel ingrowth and angiogenesis by producing VEGF, modulate fibroblast invasion by producing TGF-1 beta, okay, and interleukin 10, and production of extracellular matrix. The macrophages themselves display considerable heterogeneity in their function, often express activators as well as inhibitors, that is the pro-inflammatory markers as well as the anti-inflammatory cytokines, depending on the evolution of a particular host response. Therefore, the study of macrophage biology and their involvement in human diseases is an avenue for potential therapeutic interventions. Thank you so much for your patient hearing.
Thank you so much, Dr. Shristi, and sorry for that interjection.
No problem.
A wonderful presentation, excellent. This is so good and so extensive. I think everybody should go through this to understand the basis of so many other things like the cytocoms, cytokine storms, and the rest of it, and to understand the cell biology of monocytes and macrophage to understand its pathology. Wonderfully presented, excellently done. Real hard work, so wonderful.
Thank you so much, sir.
Let me just see if there is any questions on the video. Right, there aren't any questions there. So I would request you to share the PDF of this lecture.
Yes, sir. Yes, sir.
Sure. Thank you so much, Dr. Shristi. In spite of not being well, you have done a wonderful job. As usual, you're an excellent speaker, a very good orator, and the content was too good. Very, very nicely done. Thank you so much. God bless you.
Thank you so much, sir. It's an honor, sir, to be a part of this series.
Thank you. See you. Bye-bye.
Thank you, sir. Good night. Bye-bye.
Good night. Bye.